As we know, David very rarely speaks off the cuff. But I mean, somehow you've magically done it. Talking about flow measurement, I think it's now time to introduce Vipin to tell us about assessment of graft flow and the success of surgical revascularization.
Okay, I think over the course of the day we have heard debates about the merits of complete versus incomplete revascularization. We have heard about different techniques for doing coronary artery surgery. We've heard about different conduits. But we would all agree that the purpose of coronary artery bypass graft surgery is to perform an anastomosis, and all would agree that if the anastomosis is patent and is functional, that's good. Okay, so today I'm going to talk about various methods of assessing intraoperatively graft function. Early graft failure may occur after coronary artery bypass graft surgery, and it can lead to a number of complications. It can lead to refractory angina, infarction, arrhythmias, and even mortality. And although most surgeons believe that this is a rare occurrence, studies using intraoperative and early postoperative angiography have shown that there are significant variations in graft patency rates. And the incidence of early graft failure is about 5% for internal mammary arteries and about 10% for saphenous vein grafts. This finding suggests that there is need for intraoperative assessment of bypass grafts that will allow early detection and revision of these grafts. The hypothesis is that if defective grafts can be detected and revised in the operating room, post-op graft patency can reach 100%. So how do surgeons assess grafts? There are a variety of techniques, and these are usually subjective. Surgeons assess the resistance and perfusion beyond a graft by flushing fluid through the vein graft before restoring flow. They can observe and palpate the grafts after flow has been restored, and some surgeons would routinely insert a Parsonet probe through a partially completed distal anastomosis, and these are some of the techniques that surgeons use. However, these techniques are very subjective, and there is need for an objective method. An ideal method would be one which is easy to handle, that should not take a lot of time, should be minimally invasive, should provide easily meaningful and easily understandable data, should be cheap, and should provide objective parameters rather than just qualitative criteria. So I'm going to talk through a few techniques that have been used over the last few decades for assessing intraoperative grafts. Intraoperative angiography has been considered the gold standard in the past. However, it is not a technique that can be recommended for every patient in every operation theater because of the shortcomings it has. It requires complex instrumentation, is very expensive, is very invasive. It requires catheterization and injection of iodine contrast, and it is time consuming. On the other hand, the pictures that we get from intraoperative angiography are very good. This is a case of a saphenous vein graft going to the posterior descending artery and shows compromise of the graft by a chest drain. And after the chest drain has been repositioned, you see a good result. Here is another example of intraoperative angiography. You can see a kink in the vein graft going to the obtuse marginal and a vein valve. And after PCI done intraoperatively at the same sitting, you see a good saphenous vein graft and more collaterals distally. Epicardial ultrasonography is another way of assessing grafts intraoperatively. It uses a probe which visualizes the geometry of the anastomotic site, and added value is obtained by using color Doppler technology. However, there are a few limitations. The interpretations of these images are subjective, and it depends on operator experience. And even in the best technical setup, there is no functional data regarding runoff. Another technique that has been used recently is the SPY imaging system. It is based on the principle that indocyanin green, when it is illuminated by laser, it becomes fluorescent, and the fluorescence is captured by a video camera at the rate of about 30 images per second. Now, here are some images produced by the SPY technique. Here's a radial artery which has been grafted sequentially to the obtuse marginal and the circumflex, and the proximal portion of the radial artery is not seen. And after the proximal end of the aorta to the radial artery is constructed, you can see the proximal portion as well. This is the example of a left internal mammary artery which has been diagnosed, which has been anastomosed sequentially to the diagonal and to the LAD, and this particular portion of the lima is not seen. And after the diagonal anastomosis was revised, you can see the full lima. Now, with the SPY images, you can get good quality pictures. However, this happens only in cases where the conduits are skeletonized or in the proximal portion of vein graft. And all the pictures are not very clear, like the ones I have shown. On the other hand, SPY has a lot of advantages. It does not need catheterization, X-rays, or iodine contrast. It takes only a few minutes to do this, and indocyanine green is a very safe drug. Okay, electromagnetic flow meters also can be used to assess flow. These flow meters are used very commonly in industry, and they give accurate values. They're used in water pump stations and in the petrol stations, in the retail petrol stations where we fill up our cars. And in the laboratory, they give very accurate results. However, in the clinical setting, they are not as accurate. The main shortcomings are that you need probes which have to fit the conduit very well. There is a constant need for zeroing, and also the flow measurements depend on the hematocrit of the patient. So they have not really caught on. And in clinical practice, in coronary artery surgery, where we have small conduits, they are very rarely used. This is another way of assessing graft flow. This relies on online pH measurement of the regional myocardium. You have pH electrodes which are inserted in the muscle, which is subtended by the coronary artery that is being grafted. And when the cross clamp goes on and while the distal anastomosis is being performed, you see increase in acidosis because of anaerobic metabolism and and collection of hydrogen ions. And when the flow through the lima, in this case, is started, you can see the acidosis decreasing. So this technique also can give you information about the adequacy of the graft. Calibrated pump flow. In this particular technique, cardioplegic solution is pumped through the proximal portion of the saphenous vein and at a pressure of 100 millimeters of mercury. And this is a pre-calibrated pump, and the revolutions per minute give you an idea, gives you an estimate of the flow through this particular graft. Many groups have shown that the graft flow measured with this technique correlates with graft patency in the postoperative period. The advantage of this technique is that it is done while the cross clamp is still on. So if there's a problem with the graft, you can correct it. The disadvantage, of course, is that it cannot be used for pedicle grafts like the left internal mammary artery. Thermal coronary angiography uses infrared cameras to detect temperature differences between the graft injectant and the surrounding epimyocardium, resulting in a heat picture that you can see over here. A temperature difference of 0.1 degrees centigrade can also give very clear pictures. And here are some examples. This is the instrumentation that is required. It's not very complex. Here's a vein graft to the left anterior descending artery. Now coming to TTFM, which is the focus of my talk, this technique, transit time flow measurement technique, relies on ultrasound for the non-invasive assessment of graft flow during coronary artery bypass graft surgery. It is based on the principle that ultrasound traveling against blood flow will take longer to reach the transducer than ultrasound flow moving along with the blood flow. And the difference between this time, the difference in the transit time, is used to quantify flow. It correlates linearly with the blood flow. And a trace that you get from this TTFM measurement gives you information about the graft or vessel condition. Now, many investigators have validated the measurements that you get from transit time flow measurement. They have compared the values obtained by transit time flow measurement and have compared this with volume sampling and have found excellent correlation. So what you measure with TTFM is what is actually present. The instrumentation is not very complex. These are some photographs from our theaters. The probe is a handheld probe, and they come in various sizes ranging from 2 to 5 millimeters. The probes have to go around the conduit. This is a monitor over there, which is a touch screen monitor, and via the monitor you can control the output of the probe. In our theaters, the computer is also connected to a printer. So after every graft is performed, we print out a flow tracing for every individual graft and put it in the patient's case notes. The parameters that you can get from TTFM measurements are listed over here. You get the mean flow, the pulsatility index, diastolic flow percentage, and the backward flow percentage. The mean flow in this particular tracing is 33 mils per minute, and aside from when the flow is zero, that is a clear-cut indicator of a graft that is failing. Aside from that, there is no particular value that you can that can be considered a standard value for a particular conduit or a particular target. The flow depends not only on the patency of the anastomosis. The flow depends more on the runoff and the distal and the quality of the distal coronary artery. The next parameter that you get is the pulsatility index, which is a ratio of the difference between the Qmax and the minimum flow and the mean flow. Now, in this particular patient, is there another one like this? I can't. This doesn't seem to be working. Okay, in this particular patient, here it is. The Qmax is about 60. And the Qmin is minus 20, so the difference is 80. The mean flow is 33, so 80 divided by 33, you get a pulsatility index of 2.5. The lower the pulsatility index, the better. It is an indicator of the resistance of the distal coronary artery tree. And higher the pulsatility index, it's not very good. The chances of graft failure increases. Above 5, the chances of graft failure are high, and below 3, the chances of having graft failure are very low. Diastolic flow is the percentage that happens during diastole. In this particular recording, you have 86% diastolic flow, which is in the normal range, and the backward flow is the part of the tracing below the zero line. So in this particular patient, in this particular graph, it's less than 3%. But before we discuss backward flow, let me just put up this slide to discuss coronary perfusion. Now, we know that the majority of coronary perfusion happens during diastole. In systole, the intramuscular blood vessels are compressed and twisted by the contracting heart, and blood flow to the ventricle is at its lowest. And in systole, the intramyocardial blood is propelled forwards into the coronary sinus and backwards into the epicardial vessels, which act as capacitors. And the coronary perfusion pressure is the difference between the aortic diastolic pressure and the left ventricular end diastolic pressure. And of course, these changes are less pronounced in the right ventricle because the pressure differences are less. So coming back to backward flow, this particular, the tracing below the zero line is less than 3%, and it is an indicator of a good graft. If you have lack of, now I will take you through a few scenarios of tracings that are obtained with TTFM and what do they mean in practice. Now, patients who have, or in grafts that have no backward flow, and if it is associated with a spiky systolic pattern, it indicates problems with the anastomosis, either an intimal flap or a purse string effect, heel or toe tapering, or even acute thrombosis. And that would be an indication for redoing the graft. And these are some guidelines over here in the next few slides. If you have a combination of a high mean flow, a low pulsatility index, and a diastolic waveform, as you can see in this particular graph, this is a good graft, and the chances of having post-op ischemic episodes will be very low. If you have a combination of a high pulsatility index, a mean flow less than 15 mils per minute, and a backward flow more than 3%, as you can see in this particular graph, the chances of having problems are very high. And in this particular scenario, as you can see, even though the Qmax is at the 10 range, just because the backward flow is so high, the numerator in the pulsatility index calculation would be very high, and therefore you'll have a high pulsatility index. Some authors have called this functional obstruction, and this can be seen in arterial Y grafts, where the two limbs of the Y have been anastomosed to coronary arteries that have different degrees of stenosis. And this is also a competition of flow. And if you see a trace like this, and if you clamp the artery that is stealing the blood, you will find that the trace goes back to normal. And if that happens, and if in the original tracing, the majority of the tracing is below the zero line, that would be a very strong indication for taking down the Y graft and performing the anastomosis of the stealing branch onto the aorta. If, on the other hand, the original graph shows less of a backward flow and it is near the zero line, in those cases you can use noradrenaline to increase the systolic pressure, and if that increases the mean value, you could actually keep the Y graft as it is. Another marker of poor performance will be a combination of a low pulsatility index but associated with a low mean flow value and a backward flow near zero. In this particular tracing, as you can see, the backward flow is not existent or near zero. If in these cases the noradrenaline test shows that the mean flow does not increase, it is a sure shot indicator of technical problems with the body of the graft. There could be a dissection, hematoma, or stenosis of the Y graft.
Vipin, sorry to interrupt. Could you try and sum up so that we can open this for discussion, please? Thank you.
So I will skip. There are some more scenarios here that I will skip, but let's look at the evidence. There are no randomized trials, so we'll just look at the observational studies that are present. The biggest study is one published from Canada by Kaiser and colleagues. They looked at 1,000 arterial grafts. They looked at the parameters that I discussed over here. And in their study, they did not use TTFM values to revise the graft. They based it on clinical criteria. And they found that pulsatility index correlated very well with MACE. They followed up their patients for 3 years. The patients who had a low pulsatility index had a less incidence of MACE, 6%, compared to 17% MACE for patients who had higher pulsatility index. Another study was from Besit in Turkey. It was a case control study. They looked at 100 patients pre-TTFM measurement and 100 patients after, and they found that their use of intra-aortic balloon pump was less when they started using TTFM, and their incidence of peri-op MI was less as well. NICE has looked at this particular technology. They have looked at the cost implications, and you can read the NICE guidance in more detail. But what they have found that using TTFM, the equipment costs 111 pounds. It takes a few minutes to do this, and the graft revision rate, because of using TTFM, is about 6%. And this is the cost of graft revision. And on the plus side, the incidence of MI, if it comes down from 5% to 0%, saves 1,667 pounds per patient. The cost of using intra-aortic balloon pump is about 2,600 per patient, and the incidence comes down from 7 to 1%. What NICE has come up in their calculations is that by using TTFM in every patient, there would be a cost saving of 111 pounds. So in conclusions, TTFM ticks all these boxes. It is an easy method. It is not time consuming, does not need catheterization or iodine contrast, provides easily meaningful data, and provides objective parameters. So my last slide, David. And therefore, I believe meticulous operative techniques should be supported by intraoperative TTFM in completed bypass grafts, and that will improve results.
Thank you, Vipin. So I think at this point what we'll do is open it up for discussion for about 10 minutes or so, and then Professor Cole will actually tell us, have we succeeded in improving the results of CABBAGE. Let me first ask from the floor, any questions? Okay, while you're thinking of questions, because I'm sure somebody must have a question. In my own hospital, we have used extensively the SPY camera and TTFM. And we published this in JTCVS, that the problem with TTFM is, as Vipin said, so in 90% of the grafts you assess, you get great, very convincing pictures of diastolic flow, low pulsatility index, and high flow in your grafts. So you know the graft is fine. But what we reported in JTCVS was that about 1 in 10 grafts had a relatively low flow and had so a relatively low would be a flow less than 20 mils per minute, accompanied by a pulsatility index above 5, so say 7 or 8. And you were then left wondering what to do with this graft because it fell outside the normal criteria. So we ended up revising 1 in 10 grafts. And in the vast majority of these grafts that we revised, we couldn't find the problem. So we re-anastomosed it, and then we ended up with the same figures again, and we just said, fine. And what has happened since then has been a major improvement in this system. So the original system was just TTFM. It's made by Medistim, and they now have a new system called VeriQC. And what this does, it combines TTFM with a small echocardiographic probe. And the crucial thing about this is it allows you to visualize the anastomosis. Because what we were doing before, many of the grafts we were revising was because of competitive flow in the native circulation. But we couldn't be sure about it. And now with the new system, so you measure the flows, 90% of them are very convincing, you need to do nothing else. But in the 10% where you've got lowish flow and a higher pulsatility index, by actually visualizing the anastomosis echocardiographically, you can see the flow in and out of your anastomosis. So you know it's patent and you know that you do not need to revise that. So I think there's been a major improvement in the system over just TTFM. Any questions from the audience about anything? Please.
Professor Taggart, what about probing the vessel during the anastomosis? What do you think about the oldest method to assess the patency during the anastomosis? Thank you.
When we
probing to stick a probe.
Yes, I understand. We're all influenced by both science and anecdote. And when I was a senior registrar at the London Chest Hospital, this is like 20 years ago, I operated on a 44-year-old man when my consultant had got off. And in those days, consultants could go to the private clinics in the afternoon, so that's how long ago this was. And I remember in this 44-year-old, we used to routinely probe coronaries. Anyway, I had difficulty getting this chap off bypass, young man, and to cut a long story short, he eventually died. And when we looked at post-mortem, what I'd done was I'd elevated a plaque distal to my graft, blindly with a probe in a heavily diseased coronary artery. So I think whenever you're probing, you've got to be very aware that there's a potential downside. Now, that only happened to me once, but of course I never probed another coronary after that. And but it still sticks in my mind that if I hadn't probed that coronary artery, that chap would probably still be alive. So I think probing is a potentially crude way of doing it. And I guess if that was my only option, I'd squirt a syringe of saline down it rather than probe a coronary, particularly if it's a diffusely diseased coronary artery. Yeah.
Can I just ask a question? How many in the audience here use anything other than a probe, a syringe, and the Mark I brain to work out the flow down a coronary graft? 4. So this is a minority sport, isn't it? Without any doubt whatsoever. But I mean, I'm definitely hearing that this is useful.
Yeah.
So I mean, this is convincing me a little bit that this might be something that I might want to get into.
I mean, one of the points I would make about this is, if you think about it, an interventional cardiologist who does something without any of the degree of complexity that we do will always image his result to make sure he's achieved what he set off to do. And if you bear in mind the fact that the one thing you do to change a patient's life expectancy, so if a patient leaves your operating room with a patent internal mammary artery to the left anterior descending, you've changed their long-term prognosis. And if you look in the literature, we know that around 3 to 4% of IMA grafts are blocked when the patient leaves the operating room. Now, when you start measuring or assessing your grafts, one of the things that you quickly learn is that most grafts which are blocked, there's no change in the ECG, there is no change in the blood pressure, and you're unaware of it. And you become aware of this very quickly when you start routinely assessing grafts. Excuse me. So my philosophy is that, do you have a duty, almost an ethical duty, to make sure, if nothing else, that your patient is leaving the OR with a patent IMA? Or in my case, I would say with 2 patent IMAs. And the more arterial reconstructions you do, you know that on one hand, the trade-off is potentially better long-term outcomes. You equally know that that is a technically more challenging operation. It's more easy for it to go wrong. So does it make sense, if you've done 3 or 4 arterial grafts, to make sure that these are patent before a patient leaves the operating room? What you find is that once you start using these systems, and for some reason you can't, the machine breaks down or whatever, you then actually feel slightly uncomfortable, because it's like anything like, when you have checked your grafts are patent, you know you can go home that night, you know you can open a nice bottle of wine, you know you can call your mistress, your wife, and you know you can have a relaxed evening. So it really does provide you with great reassurance, particularly when you're doing these slightly more complex reconstructions, to know that you've actually done what you think you have. Please.
It's a very important question in the practice, really. Especially, we brought the issue of off-pump. I myself am a strong believer in the shunt.
Yes.
Intracoronary shunts. Using intracoronary shunts, does it raise inside you any doubt about the anastomosis? Or once you're using the shunt, if you're doing off-pump, you are happy with every anastomosis? This is my first.
I think it's a good point. I routinely use shunts, but I mean, you have to be careful how you use shunts, because they in themselves, as you know, if you oversize a shunt, they can often be difficult to get back out the coronary artery, and then you're worried that you've damaged the endothelium of the native coronary artery. But does the use of a shunt reduce the risk of you making a technical error?
Yeah.
Yes, I think it does.
It does. I think once you have used the shunt, you're happy about your anastomosis, isn't it? Once you've used the shunt, you are happy about the anastomosis.
I think it reduces the chances of you getting technical errors.
Ones,
yes?
Yeah. And the other thing is about the venous conduits, of course. Just attaching it to the quadriplegia and measuring the flow from the pump is another easy way, I think, to assess your...
but with a vein graft, you can occlude either the toe or the heel and have still flow in one direction, and you won't know about it.
I'm speaking about the distal end.
Yeah.
If once you've completed.
Well, if you use a shunt, that's going to be less likely to happen. But you'll see that, it's well described. You can occlude either the toe or the heel.
Yeah.
And you can still have flow through either the heel or the toe, depending on the bit you didn't occlude, and you'll think that graft is normal. You would not pick it up.
Yeah. Thank you.
Please.
Thank you very much. I'd like to thank all the panel and all the speakers for a fantastic day. From the paper that was produced from Philip Hayward's group a couple of years ago, which looked at progression of disease, moderate lesions, left versus right. Left seemed to progress quicker than right side. So nowadays we have FFR, which can tell us which vessels to graft. Let's say you went to theater with a moderate lesion and you did not have FFR, and you did a TTFM, which shows that there is competitive flow. What do you do in that situation?
Well, but then you've done the graft.
Exactly.
So you
know
pray.
The graft is going to go down because you've got competitive flow. What do you do?
Yes. So if you've already done, I mean, you only do TTFM after you've done your graft. So you've already done it, whatever. But I think the key point about FFR is that we definitely know, particularly for radial arteries, that they are very sensitive to competitive flow compared to the internal mammary artery, and also compared to vein grafts. Vein grafts are simply capacitance vessels, and they will often stay open even when there is competitive flow. So if you take the scenario, for example, a right coronary artery with a 60 or 70% stenosis, the only thing that's going to stay open in that situation is a vein graft. So the advantage of FFR is that it's giving you a better true indication of the functional severity of the stenosis than you get by eyeballing it. If we see a stenosis over 90%, we don't need FFR when you really see, but those intermediate kind of hazy, slightly narrowed lesions, when you, as Fame showed, when you try to eyeball these, you may as well toss a coin, because what we're often doing is making a guess. And if you're going to do 3 left-sided vessels, then you know the best chance of survival of your arteries is to place mammary arteries and radial arteries to the vessels with the most significant stenosis. And that's where FFR can be advantageous.
I really agree with that, Prof. But it's just that if you're in a situation where you put a vein graft on a moderate lesion, or what the cardiologist told you, this is a significant lesion, and now you've done a TTFM, let's say 10% of the lesions are going to show that there is a problem with our graft. And what is in the borderline territory where you've got a bit of backflow, that's because of competitive flow. You're in a situation where you're grafted and you know the graft is going to go down probably. It's going to be in that 10% of those grafts each block in that case. Is there anything you can do to fight that?
No, I don't think there is, but remember this. If you have a vein graft that goes down because of competitive flow, in the vast majority of these cases, the patient doesn't come to harm. It's very different from a stent occluding where you have a major problem. So if a vein graft, and that was shown very clearly in the Syntax trial, even in patients in whom vein grafts had occluded, this was only picked up by routine angiography. It was completely clinically uneventful. So once you've done that graft, the point I was making was that if you've done a graft like that, and you're not sure is there a problem with the graft, could there be an intimal flap? Could there be a purse string effect, or is it competitive flow? Before you thought, well, I'll just redo it to make sure. But as I've said, with the very QC system now, with this small echocardiographic probe, you can actually image the anastomosis. Has anyone seen this in the audience? Well, try and go to the Medistim. I think they've got a stand here, but go and see this because it's actually quite dramatic because you can see the whole anastomosis, you can see flow into it, out of it, you can see the flow in both directions. And when you see that, you know. So even if you have low flow in your graft, even if the pulsatility index is higher than you would have liked, you're still reassured you cannot do better than that. So the beauty is you do not have to redo the graft. Sorry.
I think another thing you can do is, if you are suspecting competitive flow, you can actually snare the coronary artery proximally, and if on snaring the coronary artery you get a normal value, it is indication of competitive flow, and you can leave the graft as it is. You don't need to revise it.
Okay, so I'll. Oh, you want to please?
Okay.